Hello, everybody. Welcome, folks. Got loads of stuff to talk to you about today, just a little bit at the top from me. So this is a really interesting piece of work that we've done in partnership. As more and more data becomes available to us, we collect it as part of our ongoing reporting. One of the key barriers that we have when we talk about SMD is identifying people that have other stuff going off, particularly when they engage in, one service that addresses one facet of that. So what we're going to show you today is how we've worked in partnership across the Trust and Changing Futures in the ICB in order to be able to increase identification and prevalence of people experiencing multiple barriers to ongoing care, in this case in mental health support. I'm joined by Laurie and Laurie, who are analysts, and what that's kind of unlocked is their expertise on that data combined with what we know about how people with multiple sort of disadvantages move through the system. We've been able to use a snapshot to be able to understand a better methodology to find these people, where we've used various bits of inference models and recording that already exists. Laurie will talk you through a bit more of that. And then more importantly, where do they show up? So what is the relative prevalence of them? What is, on any given service within the Mental Health Trust, what is the ratio of SMD to non-SMD to our best guess? There are so many applications of this, and what we've got here is just a start for 10. It's a real foundation, but it's exciting to be able to, as data becomes more and more important, and as data linkage becomes more and more important, we can start to move to that more preventative piece. It opens up that idea of being able to understand what return on investment and relative cost looks like for poorer outcomes that are consistently achieved. How we can improve that. How can we improve how people move through the service to get better outcomes, despite the challenges that they face outside of, in this case, mental health support that they receive. So I'll come back in at the end to talk about a little bit more around how we can apply that. But ultimately, this is now over to Laurie and Laurie to introduce themselves and take you through the deck. Thank you very much.
So I'll introduce myself first and then hand over to Laurie. So my name is Laurie. I'm a principal mental health transformation analyst. So I work specifically normally with mental health data and anything new and exciting kind of going on. So that's how I first became involved in SMD. And then I'm just very excited about a lot of things. So ended up here. Laurie.
Hello, I'm also called Laurie, confusingly, and I'm also a data analyst working for Knox Healthcare. I normally focus on health inequalities, and that's across the trust. So we have mental health services, we also have community health services. So I work across the patch, and SMD is relevant to health inequalities, as I'm sure you'll all be aware. And that's me.
So to give you just a bit of a brief overview about the mental health services offered by NHFT, because some of you I know are from NHFT and some are not. So when we talk about community, we are talking about this wide variety of services. We've got our general community services, which are sometimes called our LMHTs and CMHTs. We've got specialist services for things like perinatal and eating disorders, and we've got specialist therapies such as for personality disorder. Within our general community teams, one of the offers we have is the AI pathway. It used to be called AO, which is assertive and intensive. So this is often where people are seen frequently. Staff go out to them rather than relying on patients being able to make it to our medical centres. Then we've got UEMH, which is urgent and emergency mental health. So we've got a variety of service in this. We've got the crisis teams. We've got liaison who see people in the emergency department or in the acute hospitals with a mental health need. We've got liaison and diversion that sees the people in custody quite often. And then we've got specialist versions of this, for example, for the learning disability population, for our older adult population, children's, etc. Then we've got inpatients. Some of these overlap with the acute trust, so wanted to clarify. Acute is our general psychiatric units. This is generally where people start off in their admission. They can be there informally or they can be detained under the Mental Health Act. Our PICU, which is a psychiatric intensive care unit, people that are escalating, they need a higher level of security of their environment, and these patients will generally be detained, so subject to the Mental Health Act. Then we do provide forensics, so we've got in our trust low, medium and high secure settings. We don't cover them massively here because of the different systems, but people then stay there a lot longer. Again, some patients are there through community, they just needed the environment, others are on judge orders. And we've got a couple of specialist units hiding around. But today, when I hand over to Laurie for inpatient, we're focusing generally on just acute and PICU. So generating the patient list, why do we have to do this? So we have something built into the EPR, which for us is Rio. And don't know that slide's right. Which Hayley, who I know is here somewhere, so for naming you Hayley, got added. And this allows people to tick the 5 different criteria that can fall into SMD, and it brings up a flag on their system. So as soon as you open that record, it says this person might be experiencing SMD. However, because of this is fairly new, it's about 18 months to 2 years old now, and trying to get this message out, you know, in our trust, we've got something like 6,000 mental health staff across all different areas. Some people that will work with SMD, some that don't necessarily know that they work with SMD, and so on and so forth. We decided to use other parts of RIA that were well filled in to bolster that initial bit. We also know that once people start acknowledging that this is necessary to record, they record it better. So we had to do this essentially a proof of concept. So as I said, that the thing that's ticked in is part of the CCI, the compulsory client information, that's not particularly well filled in all the times. But there's things that we can infer. So for mental health, if someone has been open to a mental health treatment team, we can infer that they've got mental ill health. For forensics, we can see if they've been in a secure hospital. We can see if they've been open to any of our forensic teams. We can see if they've been assessed for their mental health in a forensic setting. Substance use, again, we've got some risks assessments that mention substance use. We've got a substance use team, and also some of the forensic teams see almost all of their patients are substance use. Homelessness, again, we can look if they've ever been NFA on their address or if they've been open to our homeless teams. And domestic and sexual violence, again, we've got a team for that, but we also have our risk assessments which cover this. So we can pull the information from all of these places so that the people that don't know that this is there in the CCI, we don't miss their patients. So these are our headlines that we'll go into more detail about. You know, 20% of contacts in the last 12 months were for SMD patients. They did make up 30% of the UEMH access, which is sort of that high level of care. Again, they are 40% of our inpatients in acute and PICU, but they represent over 50% of our readmissions to inpatient care. And we generally monitor that on a 30-day and a 12-month basis. So as you can see, there's already something quite apparent about the disproportionate use of some of that more intense use of services, which often comes with a loss of liberties when you're detained under the Mental Health Act. So it's really important to start with. Basic demographics. So as we said, they have got 20% of contacts, and they make up slightly more contacts than patients, i.e. they're seen slightly more frequently. So that's what we're working on about this sort of 20% of patients and contacts. When we look at how likely are they to have had perfect attendance, i.e. not DNA'd in the last year, that is a lower proportion for SMD, but makes sense with the barriers that they face. And so less likely to have perfect attendance, more likely to not attend. This was not a surprise to anybody. Then we look at their ethnicity. So SMD is overrepresented in a lot of the BME communities, which we know also can add to some of the barriers that people are facing. So for example, in the Black community, 2.6% of our non-SMD patients are Black, but 7% of our Black patients. So again, it's giving us an idea as to where we need to start considering and focusing. Gender, so mental health services tend to see more female patients than male at about 2 to 1, and SMD is the reverse, with about twice as many male patients identified as SMD as female, which is not surprising. SMD is generally overrepresented in males, but it's still curious to see the discrepancy. When we look at where the patients are, so they're very well represented in Nottingham, but part of this could be some of the data recording as well, because that's where a lot of focus was put. They're also represented quite highly in the homeless population. Again, not surprised given that it's the criteria. But we can see, for example, that Mansfield is equally represented within both groups. So we've got a little pocket of SMD up there as well. Finally, which links to that, deprivation. Again, SMD patients far more likely to be in the more deprived areas. Not applicable deprivation applies to generally our homeless population or people that don't live in England, and most of the time for us it means homeless. none of this is a surprise, I think, to anybody, but it was really useful to be able to see sort of more of the concrete facts and figures. So now we need to look at how they come into services. Where do we first encounter them? If we go right back to the start, how do we bump into these patients? So when people come into services, how risky are they presenting? So the way that we determine this is we've categorised our teams into 4. In a high crisis support, generally that team can respond to you within minutes. So again, we're looking at UEMH, we're talking about crisis and liaison. If we're going to measure how long from being referred to being assessed, we generally measure that sort of in minutes. And they're 24/7 type service. A medium crisis support is your general LMHTs that will respond to you generally same working day within a couple of hours type response time. Low crisis support is often some of the specialised therapies that will get back to you often within a day or two. And no crisis support, we've got a small number of services that are either diagnostic, so we'll just have to refer you to somewhere else, or like our recovery college that can offer a certain level of support but are not geared up. And as we can see, that the SMD population are more likely to come in more intense, which is often a bit of a proxy for they are more unwell when they come to us. We're far less likely to meet them, as say, at the diagnostics level, far more likely to meet them, as say, in quite a severe level of distress, hence they're ending up under crisis, street triage, liaison, etc. Then we look at how old they are when they come into services. A good chunk of them are coming in actually as children. They're under 18. So at the time, we may not have identified all of the SMD things yet, but they have been kicking around mental health services since they were little. So how do we make sure that, for example, our CAM services, because SMD is often focused in 18 plus, how do we make sure that the under 18s are considered? Is this a focus for prevention and so on? But it was really enlightening to see that we've known them since they were little. Again, over 65s tends to be, we meet a lot of people at that age coming for a dementia diagnosis. Often that's their first interaction with us, which is incredibly rare for our SMD population. So if we then look at how long, so the people we saw last year, how long had we been seeing them for? And as I say, even without looking at the numbers, you can see that massive discrepancy between the red and the blue, with the red being SMD. The median average for people with SMD to have been in services is nearly 12 years, which thus means that more than 50% of the SMD patients we saw last year had been known to Notts Healthcare for over 12 years. So they're around, and I don't think we'd quite expected the number to be quite that drastically different, but it does tell us a lot about how they engage, how they are here. But there's often this sort of theory that they're not in services, but they are very much in a lot of our services. When we look at the current level of team and support that patients need, so as we described earlier with these sort of crisis levels, our SMD patients are more likely to be in a more intense team, which again just corroborated everything that we had seen, which says a lot about the way that they engage and the level that they engage at. Often they do, although they've been around for a while, sometimes they don't come back into services until they are very unwell again. So it's how we get there sooner. Secondary care referral. So where are they in? As we can see that although they were although they were 20% of our overall patients, as we discussed earlier, they were overrepresented in accessing UEMH. And again, this is based on number of referrals right now. This is the number of patients. And so this, again, gives us a lot of information about, okay, if they're coming into crisis services first and they're going there a lot, how do we empower our crisis services, our urgent and emergency care services, to be able to respond in a way that works best for this population? Because they are used to seeing a certain level of chaos and distress in ED, because if any of you have sat in ED, you'll know that chaos and distress is a fairly common feeling for everybody. But how do we get them to understand the extra barriers and so on? We then look at, let's say, the UEMH teams in specifically. As I said, we had a large selection of them. So the highest red bar is liaison and diversion. So they're the people that assess patients in custody. And from having done a bit of a case note thing with them, all of their patients are SMD. We could not find a single patient that didn't meet the criteria, because obviously if they're there, they're being assessed because of a mental health concern, they are in a forensic environment, and the vast majority tend to have had some sort of substance use that led them there, and if not that, homelessness. So everybody in liaison diversion has SMD. We can then see that they're very represented in liaison, which is our ED services. And from some of the other information that we've got nationally and a little bit locally, we know that SMD patients do use A&E services differently. And quite often I say, if you've not got a GP that you can access, or you can't make appointments, because I know a lot of people struggle to make their GP appointments, ED you can rock up when you need to rock up and when something's happening. So overrepresented there. Same again with street triage. This has got a slightly policey element to it. So we've now got a policeman and an ambulance one, where if a call comes into them and it's deemed to be predominantly mental health, there is a car, ambulance van, whatever, that can go out and see them. So again, they do tend to see a lot of homeless patients. Crisis resolution is overrepresented in referrals, but there comes a slight challenge that when we're talking about a home treatment team for the homeless population as to how they can engage safely for everybody. Intensive community assessment treatment team and intensive home treatment teams, they're our specialist services. So ICAT, the first one, sees learning disability patients. Intensive home treatment sees older adults, not exclusively dementia, but a large proportion of dementia. So that's why SMD is very low in those numbers. They're also much smaller services. So this is just that they've met those teams, but now if you start looking at repeated usage, which can often be a proxy again for distress and challenges in accessing the normal services. So keep clicking. So as we can see that liaison is the main place where they're really overrepresented. If we're looking at people that have had 3+ referrals in 12 months, which is not that uncommon for ED overall, we can see that the difference between the blue and the red bar has suddenly swung greatly here. And that, again, was not a surprise to anyone, but it was really useful for us to be able to see the actual extent of that difference. And again, will help us work out how to support both the mental health side of ED, but also the acute side of ED to address these patients better. Although we'd seen before that obviously intensive home treatment and ICAT are very small numbers, and they are very small numbers, we can see slightly more prevalence when it comes to repeated referrals in this cohort anyway. And again, repeated use of crisis team, street triage, and so on. So then if we come back to our standard community teams, so again, this is sort of what people might know as the LMHTs, CMHTs, the CAMS team, the learning disability team, that sort of very generic catch-all service that do a lot of work with a wide array of patients and very complicated patients at times. We can see how many referrals have they had. So both referrals where they were seen and referrals where they weren't seen. So we can see that SMD do get a lot of referrals. There's not as much of a challenge as some of us maybe expected in getting them into, or getting them, to knock on the door of these services. And yeah, so we're nearly twice as much in both of them for SMD. So that they're around. If we then focus on that assertive and intensive pathway, as I described earlier, it used to be called assertive outreach, now it's assertive and intensive pathway. This is for patients that are really unwell, that are often at risk of being admitted if not treated in this sort of way. Generally, if any of you have been to mental health services, you might hear them sometimes called cluster 16s and cluster 17s. So often tend to be very representative of a psychosis presentation, with substance use, or just with a very poor history of engagement and medication non-concordance. So a lot of these patients will be on depot injections to try and ensure that they take meds without having to take tablets every day, and will quite often be seen on twice-week visits at a high intensity and out in the community. I say the reliance is not on the patient to get to us, we go to them. And what we can see is this very high representation of SMD patients in this pathway, where they're making up for, say, 20% of the other pathways, but 75% of the assertive outreach pathway, which currently has allowed us to have some conversations, and we're trying to work hard to make that pathway as SMD informed as possible, given this major overrepresentation there. But it also works well in the sense that because this pathway works on meeting the patient where they are and trying to break down the barriers for those that are difficult to engage or that have a difficult time engaging, because it works both ways, it suits very well for the thing. And as we said about interacting, if we look at then specifically where the contacts are happening, so, you know, if you're an SMD patient versus not, where are you going to be seen by the community teams? So we can see, which is really positive, this reduction in those seen in a medical setting, i.e. where they've had to travel to the clinician. We can see that number is slightly lower for the SMD patients. This is for a combination of reasons, partly for the AI pathway, partly because we also have got some specialist teams that see a lot of SMD patients, for example, our homeless teams, our substance use teams and whatnot. And they have got quite a high focus on getting to patients and getting to them and breaking down the barriers that way. We can also see that they're less likely to have a virtual appointment, but as we know, this group are likely to have issues with digital poverty or maintaining a phone number and various complications. So they are more likely to be seen at home, they are more likely to be seen in a criminal justice setting, and they're more likely to be seen in a public place. So, which is a really positive start in trying to see people where they are and where they need to be and not forcing them to come to us when we know that's a challenge. So when someone's referred to us and we don't see them because a referral is sort of decided not to or the patient opts out, as we can see, SMD patients and non-SMD patients look the same. So SMD patients are not more likely to decline an assessment, which I think was quite a surprise to a lot of us as we worked on this, that getting them in for that first appointment is the same odds whether you're SMD or not. The excluded category for anyone looking at that is, for example, if a referral is closed because someone has gone to prison and they're likely to be in for a long time, we cope with short-term prison things, if they move out of area, if they're transferred to another team, or unfortunately if they have died before we got to see them. So this was quite a big surprise to us, that I say it's about 20% of patients are not assessed, but that's the same for both. However, if we then look at why people leave services having started to interact with us, what we can see is now there's a disparity, and this client choice, so the person not engaging, increases in the SMD group. So the challenge we've got is not getting them into our services per se, but it's about keeping them here. How do we make sure that we make this work in a way that suits their needs and their thing? You know, we've shown a certain level of willing in the fact that they've come to that first assessment. They've started coming to appointments, but we are seeing and demonstrating a group who, once they're here, don't feel like they're getting their needs met. The treatment's not necessarily what they wanted, or it's not been able to balance the conflicting demands on a patient. Say, if you're homeless and or using substances, trying to remember to turn up to appointments at 2 o'clock on a Friday can be a major challenge. I mean, I've missed appointments at 2 o'clock on a Friday and I've just been sat at home. So it's quite simple for everybody without all of those added barriers. So we need to make sure that we find ways to meet with them and meet them where they are. So we've seen some positive stuff of that already, but this information, particularly for community and where we've been trying to share that information with teams in light of everything going on in Notts healthcare, we are starting to see some improvements. We are starting to be in some of those conversations. So I'm now going to hand over to Laurie for our admissions.
Brilliant, thank you. Yes, so that was all about our community services, so outpatient mental health services. I will now talk about our inpatient services, so mental health wards, and what the SMD picture looks like there. I don't have too many indicators or slides to go through, just a few. I'm going to talk through 4 different indicators, and the definition of those indicators are here on this slide. So just in case anyone's going through this with a fine-tooth comb later on, you may notice that some of the totals aren't consistent, and that's because the definitions used in each indicator are slightly different, just in case you pick that up. But essentially, I'm going to look at the admission rate, the length of stay for admissions, and then readmissions within a year and 30 days. Okay, and we'll start off with admissions. This slide. Right, so it's a fairly simple slide. The first bar on the left is essentially just the prevalence rate. So the number of SMD patients we have across the trust, so not just in inpatients, but across the trust. And that says 18%. Now, if anyone remembers, I think Laurie suggested it was 19, 20%. She calculated that on the basis of contacts. This is on the basis of referrals. Sorry to be confusing. It just helped me do my bit on the basis of referrals. The takeaway number is about a fifth of our patients are SMD patients. But the reason I'm showing that is to compare our overall patient population with our inpatient population, which is the bar on the right. And as you can see, it's about 40% of our inpatient population could be classed as SMD. Now, what that means is of the, just stay there. Of the people who are already under our care, so these aren't admissions that are coming out of nowhere that we've never heard of. Of the people who are already under our care, SMD patients are about 3 times more likely to be admitted than our non-SMD patients. That's the headline figure for our admission rate. And then on the next slide, we have the length of stay. So of the patients, of all the different patients that stay on our wards, how long are they staying? And the averages for SMD and non-SMD patients seem to be about the same. They seem to be about the same. Where they differ is in how variable their stays are. So if you have a look at the bars on the far right under length of stay standard deviation, you can see the red bar, the SMD patients have much more variable length of stay. Now, generally speaking, in our mental health inpatient services, we always have outliers with every patient group. We have some small group of patients who always stay for exceptionally long periods, and that's true for SMD, and that's true for non-SMD. The difference here is that we seem to have more SMD outliers, and the SMD outliers are staying for longer than the non-SMD outliers, if that makes sense. So we have a subgroup of SMD patients who are particularly high needs, which explains the variation. So that's the length of stay. And then on the next slide, we have readmissions. So we look at readmissions firstly within 30 days. And normally this is an indicator of an inappropriate readmission. So if we are readmitting someone within a month of discharging them, we normally think that means we shouldn't have discharged them in the first place. Now, I said before that our inpatient population was about 40%. 40% of admissions are SMD patients. Now, of the readmissions, it's about 50%. So of the people who've already been admitted once, even more of those are SMD patients. And I think the odds of a patient, an SMD patient, about 75% higher, which means in reality about 12% of our SMD patients get readmitted, compared to about 7% of our non-SMD patients. And for reasons I don't yet fully understand, our SMD patients spend slightly longer in the community before they get readmitted compared to non-SMD patients. So that's over 30 days. And then the final slide from me is on 12 months. So readmissions within 12 months of discharge. And here the differences get slightly bigger. So now we're looking at about nearly double. So SMD patients are nearly twice as likely as non-SMD patients to be readmitted within 12 months of this period. At this point, 12-month period. And those are all up my slides. Quite quick from me. And now we're back to the headlines. So I don't know if I'm still presenting at this point.
I'll jump in, Laurie. Sorry, guys. Thank you very much, both. So just to sort of wrap up, really, my history teacher always used to say, tell them what you're going to tell them what you've told them. So this is really interesting piece of work because we've laboured for ages under the assumption of SME is really hard to identify. And I think we've given it a really good go. There's so much more we can learn off the back of this in terms of methodologies, how we can standardize it, how we can make that even sort of nationally or locally standardized across various different services. There are so many different directions we can kind of take this piece of work in. But in terms of the headlines, being able to prove what we think we know anecdotally about the people that we support across the SMD services that already exist, and showing the ratios of how they impact the day-to-day activity of services that already exist to treat one thing. When you throw in the complexities of what those compound needs do, there's so many different avenues we can take this down. So as a recap of the sort of headlines, 1 in 5 of the contacts in the last 12 months, we don't know if that then tracks to, is that 1 in 5 housing applications? In terms of the severity of it, nearly a third, let's say, of that more pointy end of support that's needed, that more intensive side of things, that comes with greater cost. It comes with greater resource, staffing. And as does the sort of inpatient side of things, that's the severity of care. And the fact that they repeat, they keep coming back. These are all anecdotal points that we know around how people with multiple barriers move through the system, preventing longer term sustainable outcomes. And the complexity of that is anecdotally understood. And we might understand that as to what that means to a person. But in terms of how that maps to people, we're only really just starting to scratch the surface. Luckily for us, we rattled through that quite quickly. So we've got absolutely loads of time for sort of questioned interactions. But I think this is really exciting because it starts that conversation of, one, if you've been excited by what you want to get, been excited by what you've seen today, this is absolutely replicable if you're sat on any sort of case notes, data of any kind. The methodology won't be exactly the same. But if you want to be able to do this, I think we can. I think we can have a good go using some of the inference and some of the practice we've done here. The best thing about this as well is Laurie have been really courageous to try and step out and do this. I've not been able to do this with any other partners so far yet. So massive thank you to Laurie to taking a bit of a punt on a mad idea. Because what we've gotten to is, again, proving that sort of anecdotal knowledge that we have in the system, but being able to make it real and show you guys hopefully gets a bit of excitement because it is replicable. And again, thank you to Hayley for setting up in the first place, showing that this works best in partnership. And as data linkage becomes more and more important, I'd love to see a world where we're able to actually track some of these individuals, information governance allowing across multiple services. That's the dream. I think that's it for our content today. So unless there's anything else Laurie want to go through, and then we'll move on to questions.
Happy to do questions.
Happy days. Nice one, folks.
Oh, thank you, Sam and Laurie. That was, really interesting. We've got a few questions here that have come through. So the first one, this was during the first part of the presentation, Laurie, where it's asking, what is the section on Rio called that collates this information? It was right at the beginning of your slides.
So I talked about what we call the CCI, the compulsory client information. I don't know if it's a standard bit of Rio or something that we've created, but in our system, it's got all the demographics. It's got about people's employment, what type of housing they're in, like are they rented or whatnot. It's got some stuff about the perinatal period. It's got loads of sort of that accessory information to a person. The ethnicity stuff's in the core Rio, but we've built the compulsory client information that we've got some control over editing is all of those other things. It's got smoking status, all of that. So that's where this SMD section lives now too.
Oh, lovely. Hopefully that answered the question. So this again is in your section, Laurie. So it says, can you give a view on how replicable this is for other mental health trusts outside Nottingham, i.e. could they use a similar methodology, which is obviously what Sam was speaking about?
Yeah, I don't, as they obviously different systems, whether you're on Rio or System 1 or the myriad of others that exist, the actual premise is the same. If you're a mental health trust, you'll have, because I say we pull a lot of some of this like more inferred stuff from our risk assessment. So, I would assume most mental health trusts have got a risk assessment form that will likely contain a similar level of risk assessment, i.e. a history of substance use or history of forensic stuff. So while, the literal specifics as to you pull this word out of this section will vary, the actual concept of, oh, okay, well, this is a mental health team, this is a risk assessment and whatnot, would be entirely transferable. And actually, we've got a meeting with another provider trust soon in my diary somewhere that is to do and discuss this exact thing.
Oh, thank you. So the next question, it says, are people who are seen in the liaison and diversion service also seen by the other mental health services? If so, which ones, and do they tend to be seen before or after L&D?
An absolute myriad. So some of them we meet in L&D and then never really see again for a variety of reasons. Our LMHTs, for example, have patients that end up in L&D, homelessness. Some are under our community forensic teams, but L&D can also be the trigger to get people into our services as well. So absolutely anything, everything. They're not exclusively our forensic patients. Our forensic team has got a certain level of a certain threshold of forensic risk someone must have to be under them, but they do offer consultation to the LMHTs to manage some of that lower level risk. So yeah, bit of everyone, everywhere. Can pull out the information specifically, but it's no different really to any other of our urgent teams, like our, ED liaison. Sometimes that's all people see, that's all they need. Other times it can be more.
Oh, thank you. The next question, it says, regarding the information on patients leaving, SMD have a higher rate of leaving by their own choice rather than the service choice. How was this measured?
So when patients, their referrals are closed in Rio, you have to say why they're being closed. So we've got something like 21 different options, and a few of them are client choice, i.e. client disengaged, client did not engage and whatnot. So based on those 21 and having had approval from clinical teams, that's how they're grouped into those options as to whether it's a service choice, the clinician's choice, or one of those weird edge cases where it's not really anybody's choice, we just can't keep this referral open.
Thank you. So the next question says, for the length of stay admissions averages, do you also see a group of SMD patients who self-discharge early and bring the average down?
Unfortunately, I didn't look at that, nor did I split the admissions by formal admissions, where they would struggle to self-discharge, and informal admission. So I'm afraid I'm not sure.
It's also not as simple as like in the acute trust to self-discharge, because I say if someone is detained then they can't, but also some people that are informal, if they become unwell and ask to self-discharge, they can be then put on a holding section. So just saying I want to leave and being let out of a psychiatric ward isn't the simplest process ever compared to a medical hospital, like a medical acute hospital. So it can happen, but it's not as common as, if someone's gone in for liver failure or something.
Okay, thank you. So the next question, it says, there's a clear pattern of significantly higher and repeated use of urgent and emergency interventions and inpatient admissions by people experiencing multiple disadvantage. Do you have a view on the implications for the trust, for example, in terms of managing health inequalities, patient outcomes, and meeting overall demand?
I know who submitted this question, and God, you made it wordy for us, Bobby. I mean, there is a lot of challenges in this, and I don't think really, there is some challenges in the trust, but actually, I think it shows much more about the patient's challenges than the trust's. Often this pattern does suggest that the trust has struggled to get a consistent engagement with the patient, because this applies to SMD and not, that once people have got a therapeutic relationship with their key worker, generally we see some of that, appearing in these other services repeatedly does die down. Doesn't necessarily stop it completely, but we can see a certain calming effect. And as given that, as I say, we see that our SMD patients do bounce in sort of through the community quite a bit, would explain why they might be appearing there. But it also comes back to, I say, if you need to see a key worker, quite often, you know, some of them will say, I'll come see you, but they still have to know where to come and find that patient on Thursday afternoon, or they have to ask the patient to come and meet them at a time. Whereas obviously liaison and diversion, they don't really get a choice. They've been arrested, something else gone a bit wonky beforehand, you know, but if they call crisis team or if they go to ED, it's very much on their terms. And we know from some of the national studies that we see that in deprived patients a lot, not even just SMD, where, you know, or people that have got very rigid employment, that they appear in these places. So I don't think there's necessarily there is an implication on the trust, but I think the focus should be on the other side. Hoping that made sense. That was a weird little ramble.
Oh, thank you for that. So the next one's come from one of Sam's slides. So it says, does the data support the idea of an SMD pathway?
It's a really interesting question. I think because we've just started this, in terms of like some of the questions we're asking, we're not exploring exactly yet some of the diagnoses and what that means from a clinical point of view when it comes to SMD. I don't think we know enough yet. I'd welcome Laurie and Laurie's view on it. For me, I like the idea of all services that people with multiple barriers and multiple disadvantages all services that they encounter being aware that actually there's other stuff going off, and actually is a specialized pathway right for when barriers are variable. So someone could be vulnerably housed, but they're not particularly homeless. And how do we draw that line? How do people qualify? I think it's a really interesting question. It's kind of system wide, and it will have specific implications for health, and then even more specific for mental health. I don't know if that's would be clinically backed up in any particular way, but I welcome the thoughts of Laurie and Laurie.
I have opinions on this, and I feel like I need to do a discredit that these are my opinions, not necessarily that of my employer, but, you know, opinionated human. So, because this question has come up not just in the SMD sphere, but also like when we talked about autism or some of these other things. And I always worry about, by having this yes and no, you know, those patients that maybe we haven't quite worked out that are SMD yet, are they going to get a hard deal out of this? So I'm always much more of an advocate for having SMD informed pathways, you know, so we've got a bipolar pathway, we've got anxiety depression pathway, we've got a substance use pathway. And I always think there's far more credit in having those to be SMD informed rather than having a specific SMD pathway, because that can sometimes lead to othering. And we've seen that in some other diagnoses, such as sometimes personality disorder. By having them on their own pathway, you get people going, oh, well, they're just off the SMD pathway. It's sort of the personality disorder pathway even. So I think I would rather have the clinically, like the pathways that help, you know, if you have bipolar or whatnot, to know how to help SMD patients than trying to lump SMD patients all together, because we know they're wildly different.
I suppose I'm a bit reluctant to voice an opinion on this, because really I'm just a data monkey. I'm not a clinician, and this is an operational decision. But my view is that SMD is a very multifaceted issue, that we're covering quite a lot of ground when we talk about SMD. So an SMD specific pathway actually covers a lot of different expertise, and that wouldn't be easy to formulate a team like that. It might be better to link up existing teams. And what we can now do on the back of the work that Laurie's done by developing this methodology of identifying patients is working out whether or not these patients are actually in contact with our various teams that would meet each of their various needs. Because we've identified these patients using a variety of different means, so some of it's inferred from the services they're using, some of it's from questionnaires basically, and some of it's from risk assessments. We can now look at whether or not each of these different domains are being serviced by us in their different areas, and that's something we could look at. And if they're not, then it may be a case of, as Laurie suggested, being more SMD informed, to suggest that all teams need to have a more holistic view about the various needs that might need to be met by the patients they're seeing, and then referring more effectively, I think would be my view, but it's an ongoing discussion.
Oh, thank you for that. So the next question, it says, do you have a technical write-up of the methodology that you could share?
Yeah, so we're slowly as a trust trying to work on making our GitHub pages open because we coded this in R and whatnot. So working on it, I can do a sort of rough put together one for the person that asked. If you want to drop me a line, more than happy to show more of the specifics that we did. And I can work out, we're just trying to work out what code we can share without getting in trouble. But because I've done this SMD flag and I've done an autism flag, would love to put it in the public domain.
Oh, thank you, Laurie. The next question is, how is the trust responding to this data?
So I want to caveat this, that obviously if anyone has watched the news in the last 18 months knows that the trust is having a tough time for a variety of different reasons. So it's not the most opportune environment to try and get some of this in, but that doesn't mean that we've not made groundwork. And I think actually it demonstrates the acceptance that this is important, the fact that we have been able to make headway with this in light of these very challenging circumstances the trust finds himself in, you know, with being under the scrutiny. Yeah, I'm going to roll with that word, that the trust is currently under. So as I said, the AI pathway, which is being redeveloped, I think Hayley and etc. go to those meetings to try and really help our specialist services that deal with a lot of SMD patients, as I said, for like example, homelessness and whatnot, are still getting the continued funding and advocacy and input that they need. The fact that we got the changes into Rio is making some progress. Of course, there's lots of progress we'd have rather happened 6 months ago, but we're trying to be realistic. So the fact that we've got that bit in Rio, and quite often, at least what I do when I bump into spaces, is those headlines, just keep dropping them into conversation because it helps people just start to understand. A lot of people are very overwhelmed over here right now. So there's only so much they can take on. And so we're drip feeding, and generally people are understanding and appreciate, you know, there's not been anybody that disagrees that this has to be a thing, but the implementation is behind the culture shifts.
Oh, thank you, Laurie. The next question is, has anyone been able to estimate the proportion of people who are experiencing SMD on the GPSMI severe mental illness register? I'm guessing not. I'm guessing not as many will no longer be under secondary mental health.
We have actually, because we've got this system called GPRCC, which for the life of me cannot tell you what that acronym means. It's a magical place where everybody puts a load of data in towards a GP record, and you can have great fun if you like data. Best description I've got for it. I don't know how else to describe it. But we have supported, Sam and I, in building an SMD flag there that works similar to this in the sense that it's got a level of inference. It's still not perfect because there's lots of data that is sort of missing, but that does allow us to look at how SMI patients are interacting with other parts of the system. So we can see, based on the SMD list that we have there, how many are down as SMI, how many are in services or not in services, are they using their GP, have they disappeared, all of that kind of stuff. So we have made a decent amount of headway, still got loads of things that we want to do, but I think that's true for every part of this SMD sphere. There's lots of excitement, lots of things we want to get to. So yeah, I don't know that we've pulled too much of it specifically yet, but I think Sam and I were still discussing this flag only a couple of weeks ago. So we're still fine tuning it before we share more of that information to try and get it as good as we can. But yeah, vaguely doable.
Yeah, a centralized view on it is a work in progress, and it will be some time. But yeah, it's absolutely in the works, and anything that I've seen off the back of it maps really, really nicely to what we presented today in terms of the ratios and numbers. So we think it's correct too. More will be revealed on that stuff. I'll keep you posted.
Thank you. So the next question is, how did you go about arranging ethics and governance and consent approvals? We're in the process of doing this to request NHS data for an evaluation in Hertfordshire, which has proven quite challenging and takes time.
So we've got away with a level of it because this is our data in our trust, and it's not this isn't research, this is just sort of service evaluation, and the ethics in that are different. I can't pretend I understand too much about the sphere, so I'm trying to be mindful of exactly what, but because this is not, although in some ways it's novel, in other ways it's not within our trust, in the sense that yes, this is an SMD flag, but the concept has got historic IG approval. For just service evaluation, knowledge gathering and whatnot, we have not had to do a lot of that because it's internal. So for example, although we do it collaboratively with Sam sees our aggregate numbers. There is nothing patient level yet. That would be our next stages. And yes, I am dreading the ethics and governance and some of that bit of it. But I know that we've got some special, and I don't know if Sam remembers this, we've got this certain approval that allows us to do a bit more with data based on what counts as being for a healthcare need and not. But I would need to default to mine and Laurie's team leader to remember the specifics of that, because I know he helped do it and I just nodded along and went, cool, I know what that means for me. Can't remember the rest of the specifics.
Thank you. So the next question, I work in CAMS and would be interested in where the research might go in terms of early identification and intervention. Are there plans to scope the research to collecting qualitative data from patients who experience SMD and how they experience services?
And I want to say yes, just because everyone I've interacted with on this SMD bit would absolutely love to do that. I don't know if there's a specific thing. I mean, when it comes to CAMS, and if you're in, I was about to say my CAMS, that sounds really possessive, but if you're in NHFT CAMS, there is stuff that we can look at internally to divulge bits of that. I mean, I would love to be able to find a way to work out exactly sort of when someone met that SMD threshold, because say we might have met someone at 12, they might not have got themselves into trouble yet with the law, but there was something there. So it is something that I am quite interested and willing to go and have a nosy with you and see where we can get to, at least to begin with, and see, you know, if it takes them what it would take. But it is a conversation that I know I had a little while ago also, for example, with Bobby about, you know, at the moment this is 18 plus, but how do we, you know, that would be the absolute great sort of part of the next step, is to understand what we can do sooner. If, you know, we want to help SMD patients, but also wouldn't it be great if we could prevent them becoming SMD?
Just to add to that as well, the sort of nadir of all of the data and analytics work that's happening in the multiple disadvantage space, it's always going to be predictive. The whole point is to be able to understand what people's journeys look like to get to a point where maximum intervention is required, mostly with the most time beforehand that person reaches crisis point. The best examples of this are stuff like the strategic insight tool that exists across London for homelessness, and other bits and pieces that consultants are doing on local authority data. But the richness required to be able to pull that together, even though the question here is around CAMS and mental health, actually there's a lot of other factors. So social care, for example, that would need to feed into that to paint a complete picture. And then the other side of it is, okay, cool, I can tell you that this person is going to become homeless tomorrow. This person is going to require a bed tomorrow. Are we in a position to be able to meet that need? It's going to require a different gearing, which, you know, all that preventative stuff that's coming out of central government around health and everything generally anyway. There's a lot of stuff that has to happen and filter down locally for us to be able to even respond to some of that predictive stuff as and when we get there. So it requires a big strategic think as to actually, if we can pursue it, great. Can we facilitate it? That's a second question.
Thank you for that. So the next question, does this work take account of any necessary signposting and referrals to other services, for example, adult social care?
So I'm not sure, obviously, we do obviously do signposting as a trust. We're not actually that great at always marking when we sign. Some of our teams are great. They've got a thing that says that they've signposted. It's not something that we've got particularly universal across our teams, so it is hard for us to know right now, you know, who has ended up in social care and whether that's because of us or because of someone else and whatnot. So we're trying to do as much as we can. We try and include them in some of the MDTs and everything, But from a data point of view, that connection, we don't always manage to record because of the inundation we've got of other demands for recording in the system if someone has a social worker, let alone all of the details. So not really, but again, we'd like to dream.
Thank you. So next question, would this sort of information be able to be shared with the national government, or are there GDPR, etc. issues?
So national government have seen this, and I think they're quite excited by it. There's more to be done to try and tie it together and formalize it, obviously, across localities. But in terms of the start for 10 level of insight, here's how many people there are, which is always the big question, really. People trying to model, what's my SMD population? And I don't really know. There are statistical ways we can get at it, but actually it's very difficult, particularly when we have different definitions, and that's a bit of a moving feast in terms of what we're defining as disadvantages, and the kind of different partners that come to the table locally to be able to contribute data and be part of the solution for people experiencing SMD varies locally. So to create a national picture of that is really, really difficult. I know that the national government have seen it. I don't know exactly how they're taking that conversation forward, but data, insight, identification and prevalence, it's always going to be the starter of this sort of thing, particularly when it's not visible. It's just not visible. So it needs to come from a place of some sort of predictive pooling analytics, which allows us to have a best guess and be wrong within the model as often as we are right, and allow people to move through those gates as people recover or actually reconsolidate different data. So it's kind of a non-answer, but national government have seen it. I think Bobby could probably talk a little bit more around what they plan to do with that, but we will be part of any ongoing conversations, particularly if this gets replicated in as many different places as possible. This is not just a mental health thing. This is doable elsewhere.
Oh, thank you for that. The next question, do you work in partnership with housing and other services across the system to propose a multi-agency approach?
Yes, it depends on which angle you're coming from. I know Changing Futures does a lot of stuff with everyone. I know clinically there is more and more happening, and there is always stuff. So I know in inpatients, obviously we discussed about some of these extreme long stayers, there is, I can't remember what they're called, the MDT, but there's a meeting with lots of people from lots of places, including housing and social care, to support those that have been stuck in hospital for a long period of time. So clinically, the answer is yes. Can there always be more? Of course, but as much as possible. Operationally, a little bit, but I'll let Sam explain the Changing Futures bit of it.
Yeah, absolutely. So Changing Futures aims to work in partnership with as many different areas of disadvantaged support as we can, and I think we do that quite successfully. Our embedded practitioners started off the whole conversation here, which allowed us access to Laurie and Laurie, which is how this stuff works, right? To be really transparent, all of this stuff for me today is a bit of an advert to say this is what we can do. If you're sat in housing or public health or social care or anywhere and you want a bit of this, give me a shout. You will have data, and we'll be able to do something to be able to get to a view of how SMD is represented in the people that you support and what those ratios look like. So if you're sat on a data set you think could be useful, and actually you really want to understand what those ratios look like, what that prevalence looks like, and what your activity looks like, and how geared that is towards people that have other stuff going off, and maybe that's why they keep coming back, we can absolutely give it a go. So please give me a shout and get into it.
Bobby, I've just enabled your mic if you did have something to say on this.
Not too much. It might be a bit of a wasted effort. Just to say that it is, I think Sam actually explained it really well, that at the moment multiple disadvantage isn't something that's been captured. It's still, there've been concepts like complex needs and those sorts of things that have been running around for years, but it's generally not picked up as a collective anywhere in the system in the way that homelessness might or substance use might. So actually coming up with a viable proxy as Sam, Laurie and Laurie have done, and then using that to demonstrate prevalence and also how it affects patterns of interaction, particularly use of urgent and emergency services and repeated use, has been something that's enormously useful. So we know that they're really interested. It went to the Changing Futures Cross-Government Programme Board. They were looking at it, and there is somebody called Claire Mortimer who is in government who's trying to work through some of the legal barriers and governance challenges around sharing data between organisations. But it's a fabulous bit of work. It does tell us something useful.
Could I just say something on this front as well? So we've identified SMD using a few different mechanisms, and one of them is that we have an SMD form. So that may sound like we're really ahead of the game with our data collection and we're in a special privileged place to identify SMD, but actually I've looked at it and only about 5% of the SMD patients that we captured came via this form. So actually, most of the patients we're identifying are coming from the services they're using or the risk assessments that we make them. And lots of different providers will have something like that. It'll be most easy in a mental health trust, I would guess, like ours. But lots of other providers will have similar bits of data that you could kind of tie together. So we don't want to give you the impression that you need an SMD form specifically like we've put together, because actually that's not where most of our data come from. It's actually a very small proportion of our data. So there's probably a lot more scope than you might imagine. Just thought I'd throw that in.
I think that's really helpful, Laurie, because you can ask somebody what their housing situation is and whether or not they're homeless, and they're probably going to give you a good idea of whether they are or they aren't. If you were to ask somebody if they're experiencing multiple disadvantage, most people are going to shrug, and most professionals aren't going to really be able to kind of pick that up either. So, I think it's a more helpful indicator that you've kind of worked on together.
Well, thank you all for answering that. The next question, it says there is growing evidence that linking high numbers of adverse childhood experiences to adult experiences of severe multiple disadvantage would be great to have a flag for that. And then you could look at prevention. It throws up the question as to whether the family members of patients with SMD are also known to mental health services.
There's quite a bit in there. Let me try and get through chunks of it, and if I forget any of it, come back. So as far as recording ACEs, it's something that gets discussed, and we've got lots of, again, random little places where you would see bits of this, but there isn't like a specific drop down where you can tick, has somebody experienced this trauma or this trauma or this trauma or this trauma? And obviously there's lots of theories out there that I won't go on about that talk about like big T trauma and little T trauma that can also link into some of these ACEs. And so there are certain things. So in CAMS, they fill in a current view that has got several things that link to being ACEs, but I don't think anybody could ever actually pin down a list of ACEs to ask someone to fill in without it changing every 3 days. And I don't mean that in a disrespectful way, genuinely, just as our understanding that increases. So in the risk assessment, because it talks about risk to self and risk from others, it has got often elements to it that do link back to some of that, but obviously will be more prevalent in our younger population than our older population. The bit about families, no idea. We don't tie people's records together well enough to be able to say it conclusively. In theory, we could try and look at who's registered at the same address and how many people, but actually a lot of our SMD patients, for example, don't have addresses. A lot of people that have experienced ACEs and SMD are actually probably less likely to still live at home if they've had a bit of a crappy time growing up. You're not gonna necessarily stay there if you can avoid it. So again, so definitely piques my interest as a question, but I don't know if we've got a straightforward way to try and get answers right now. Was that all of the question?
Yes, that was the all of the question that you covered there. Thank you. So we're on to the last question that we've got now. So if anyone has got anything else that they want to ask, we've still got a bit of extra time, so please put anything in the Q&A box. But this one is, it would be great if this sort of evaluation could be used not only to predict who may be homeless and need a bed tomorrow, but to also intervene to remove that need. I'm interested in the I can't even read that word. I'm really sorry.
Longitudinal. Yeah.
Thank you for helping me out with that element, as mental health situations can change too rapidly and dramatically without fallout. Snapshots can give a wrong impression. Are you able to follow these pooled patient journeys?
It's a really interesting point, and is kind of it's the dream, isn't it, to be able to understand that, you know, ahead of time, here's what someone's needs are likely to be, here's what intervention is exactly required, and here's how we're going to go and provide it. Well done, everyone. We've solved homelessness, and when we talk about mental health as well, we kind of need people to present, particularly in times of crisis, given how that works. Otherwise, they need to be free to be able to live their lives. When we think about SMD and the support that people need from a sort of supply side of things, so looking out there that these are, you know, the population, how do we meet the needs of them, as opposed to someone on their own, living their own life, going, I need some support from this place, I need some support from this place. And then the fact that to try and approach that from an intelligence perspective, all we've got is the fingerprints and footprints that we see when they touch the system. And that's for an individual person. So the problem that we've got from a methodology perspective is to try to aggregate that up to see not how an individual person moves through the system, but how people do, just to get a bit of an understanding. People are broadly predictable, but an individual person is very, very complex and hard to understand, unless we've got very, very robust views. So the example that was saw through yesterday combined a huge amount of local authority data, case notes specifically from people being supported, saying, I'm worried about my rent and that sort of stuff, which ultimately can lead to a very good indicator of someone becoming homeless, let's say within the next 9 months. With someone's mental health journey, without that really intensive contact, without a very thorough understanding of their home situation, of substance users, of anything else that's happening psychosocially in and around their communities, it'd be very, very hard to predict mental health episodes at all. So the best thing we can do is be available, be responsive, be informed for when they do need us, and easy to get at. Accessible is the key word, because we're not always going to be able to predict someone's journey. But if we're there, present, informed, and available and responsive for when they do need us, that improves that process for everybody, not just those that have disadvantages. And as we sort of expand the navigator model, as we get more and more informed, you know, people aren't then on their own. But as I say, that's a broader piece around how we support people generally with very, very restrictive, you know, resource. You know, we have to be moved very, very quick and agile towards the next big crisis, and actually how do we make sure that that's picked up in a responsive way. I'm sure it is in pockets, but to tie it all together for SMD, which is very broad, people move in and out of it, people move geographically as they need to access other services or get arrested and that sort of thing. I don't know what that looks like. I think it'd be really, really hard to design for, beyond the training that we're doing here today, to talk about how do we be informed, what does this look like locally, how can we be responsive. Kind of a non-answer, I'm sorry, but I think it's an ideological thing, that.
And we have done some longer term predictive things. You know, so a while ago, before we'd done this piece of work, we looked at what were the characteristics, for example, of, so we've done it for DNAs. So what you can't, it's very difficult to sometimes say that Bob is going to DNA, but if we know that Bob is experiencing these challenges, he's going to have a harder time coming to his appointment. So we've done several bits on that. And a while ago, before the shake-up, we looked at predictors for long length of stay, i.e., you know, depending on how you look when you walk onto the ward, where you're likely to have what we'd class as a short, medium or long length of stay. So we do those bits that say it's very difficult even to know who's going to need a bed tomorrow, aside from our bed list that tells us who needs a bed today. But we do try and look at some of the other things, and we're working on a bit of a acuity type tool that shows us, say, patients that are following a bit of a typical crisis pattern at either extreme. So in mental health services, we're concerned both for those that are appearing everywhere, you know, so they're in crisis, they're in liaison, they've been arrested, they're here, there, what, everything, but also those that have disappeared off the face of the earth, because that's not a good sign in mental health services often either. So we flag up both sides in our system, and we're working on developing that further for this reason that, yeah, they're the common patterns that we see, but we can't ever be sure about anything because humans.